Let's shine by seeing the best in all of us and by looking out for each other. Let's stay healthy. Let's shine together.
Hi, and welcome to Let's Talk Together. My name is Sherry Harlan. I'm Community Engagement Manager at Reid Health, and today we are talking about understanding colorectal cancer. And our guests we have two nurse practitioners from Reid Gastroenterology, and that's going to be the last time I say that entire word, and just say Reid Gastro. And today we welcome Amanda Gibson and Rachel Rodal. And welcome, ladies.
Thank you.
So, and with March being Colorectal Cancer Awareness Month, we are really happy to have you. So, probably what's some of the biggest things or the first thing on how you can prevent colorectal cancer?
Colonoscopy screening. Colonoscopies is the number one way to detect and prevent the colon cancer. So they start at the age of 45, screenings do, unless there's, problems before then or family history.
And so what common cancer can you prevent with a screening?
So a screening colonoscopy is done for screening purposes. So this would be someone that's not at the age of 45, is just a normal at-risk patient, not a high risk. Usually they're done before. But so the prepping of this preparation is for the colonoscopy is usually the worst thing the patients hate about it. But we try to accommodate, what kind of prep works the best for them, and depends on if they have chronic kidney disease, what prep they've used previously. But so during a screening colonoscopy, the physician, so Dr. Raza is the one who performs, and then we also have Dr. Latore, he's the anesthesiologist. But so what they are looking for is any detection of polyps. So polyps are a growth of cells in that area. The reason why we go in looking for polyps because we want to remove them. So that is, these polyps, some can become cancerous and some do not. But that's why we do this screening, so we can remove the polyps, and that prevents the cancer. Colon cancer. And depending on how many polyps, the type of polyps, the size of polyps, and the type of prep, if the prep is good, that will determine when their follow-up is. Someone that does not have polyps, usually their follow-up is 10 years, depending if they've had a good prep. But if they have polyps, usually they're going to have a sooner follow-up colonoscopy. It may be 3 years, 5 years. It just depends on the situation, how many polyps and the type.
And so basically the screening assists with prevention.
Mm-hmm.
Yes.
And one of the things between a colonoscopy and the polyp removal and before it can start. So where does the colorectal cancer start?
It can start really anywhere within the colon. It always, not every polyp is cancerous, but every colon cancer generally starts as a polyp. Colon cancer is the third leading cause of cancer in both men and women, but it's one of the most preventable ones that can be deterred.
And I know we have we're showing some slides, and it shows how the cells spread in the first layer. Mm-hmm. And then it shows how cancer is present. So, and once again, let's just kind of go over the colon polyps.
Mm-hmm. And any polyp that is seen during the colonoscopy, they're removed, and then those are sent to pathology, and then we get a report on them of what type of polyps there is. There could be inflammatory, there could be hyperplastic, there could be tubular adenoma, and what we're looking for is dysplasia, meaning abnormal cells, and or if there's a mass, then they remove that, and then that would, confirm the cancer or not.
And one of the things that screening tests can find precancerous colon polyps, and like you said, they can be removed before they turn into cancer.
Correct. Correct. The reason we do screenings is because polyps generally don't have any symptoms. There's no, there's oftentimes no symptoms to colon cancer. If it's caught, they're detected early. That's the reason the screenings are so important, is to go in and find the polyps before they turn to cancer.
And so a colonoscopy, is it the only screening test that allows you to find out?
Gold standard is a screening colonoscopy.
Okay.
Yes, that is the only test that is available that you're able to see and remove at the same time. There's other testing like FIT testing. It's a stool test, and that is done done on a yearly basis. But that type of test is, there's no medication that you have to hold. There's no dietary restrictions prior to that. That just tells us if there's any blood present within that sample. And then that's done on a yearly basis. But again, you have a one-step option or a two-step option. So the one step is just automatically going for your colonoscopy. If your FIT test comes back positive, then you're automatically getting a colonoscopy. And then once you get the colonoscopy and you have a history, polyps are found, then you will continue to have recommended colonoscopies thereafter. So no more other, FIT testing. There's also other stool testing that looks at DNA shedding and blood in the stool as well. So again, if that comes back positive, then it would be a colonoscopy after that. And then if it's negative, then that's done every 3 years. But again, people have to understand they really need to know their family history of colon cancer, family history of high-grade tubular adenomas, because if they have other siblings or parents that have that, they really need a colonoscopy.
Crohn's and colitis too.
Yeah, Crohn's and colitis, but that's different.
Colitis,
That's,
yeah.
So, but it's important to know the type of polyps your family, or if they've had precancerous polyps or something, because this generally will, more than likely, it may start earlier. It all depends on the insurance company, depending on what they will pay starting at screening, depending on family history of colon cancer or high-grade adenomas.
Then reading some statistics that 1 in 23 have a lifetime risk of colorectal cancer for men, and 1 in 25 for women.
Mm-hmm.
So an estimate show that people born around 1990 have twice the risk of colon cancer.
Yes.
And
They think that might be due to environmental factors and just sedentary lifestyle.
some of the other factors that increase risk include
Smoking, obesity, family history, history of inflammatory bowel disease,
gallbladder
yes.
removal, rather.
Yes.
I think a big thing is seems like the physical inactivity.
African American race has a higher, has a higher risk of.
Is that, do we know why it's higher amount?
Higher risk, yes. I do want to say back to the FIT testing and the Cologuard testing. They become less accurate the older you get, so you can get false positives and false negatives. So as we age, it can give a false positive or a false negative. So it's really recommended in the younger populations. So
Screening is anywhere from 45 to 75.
Yes.
So that's screening. You know, these patients are being screened. They have no history of polyps. So once you have a history of polyps, then it's no longer screening. You're more of a diagnostic, because you know these polyps are what turns into cancer. Okay. So you are getting these colonoscopies more often than a screening, which is 10 years. So, that's also important. Patients who have a history of polyps, patient who has a family history of colon cancer or other high-grade dysplasia on polyps, they should not be getting fit tested. They should not be getting Cologuards. They should be really just a colonoscopy is what they need.
And so that's why the screening is so important.
Yes.
Yes.
Should I wait until I get symptoms to get checked for?
No, oftentimes there's no symptoms.
And so what's some of the symptoms? That often some of them are hard to discuss, like blood in your stool,
Yeah.
change in bowel habits.
So
Yes.
patients come in and they talk about blood in their stool, change in bowel habits, weight loss. You really have concerns, and that's why you're going to be ordering a colonoscopy. And if it's before the age of 45, it doesn't matter. Those are symptoms, alarming symptoms that we need to get checked out.
Yes.
And if they're before the age of 45,
Well, if they have symptoms in regards to rectal bleeding, change in bowel habits, that is not a screening modality anymore. It's diagnostic. You're going in to look for the cause of the symptoms that they're having.
once again, what should I do if I don't have any symptoms? Getting screened once again?
Yes.
Yeah.
Yes.
Screening start at 45, and that's when you should start with the colonoscopies.
So let's go through some of the screening options.
So the first, that's what I,
The first part is the gold standard is the colonoscopy. That's the one that actually will detect and we can remove the precancerous polyps if seen. And then, as Amanda explained earlier, the fit testing and the Cologuard is the stool testing. But again, if that comes back positive, then you are required or need to have a colonoscopy.
You still need to come visit.
Yes. Yes.
So often,
the end results. And
And the result, yes.
patients will ask me, well, it came back positive, so what does that mean? It doesn't give you a result of, it's this much blood was found in the stool sample or this is the DNA shedding. It's just positive or negative. So we don't know until you actually get the colonoscopy.
And as Amanda said before, once you've had a polyp removed, the fit testing and the Cologuard testing is not recommended. Yes, it's you have the history of polyps, so it will more than likely come back positive again. So it's colonoscopy is the standard.
and part of that, probably the biggest thing is, let's talk about the preparation. That seems to be the biggest hindrance for some people.
It is. I mean, it is, we give you medicine that's going to make you empty your colon. We need to have, as much as the stool removed as possible so that we can see, or Dr. Raza can see the inside of the colon to see the polyps. It's typically, the afternoon, evening before. You come in the next day and go about your procedure, take a little nap, and then you go about regular activities the following day. So it's I never say that it's a simple or easy test, but it is important. And the prep is obviously the hardest part.
Well, we have to do we drink?
Sometimes you drink,
Something.
sometimes we drink, sometimes there's some pills, usually a combination of both. It all depends on your history. If you have kidney disease, we use one kind of prep. If you different preps are used for different situations. So it's patient dependent.
And you're looking at the patient's history or risk factors before you decide and work with them on that.
Yes.
So, and for people who cannot or will not have a colonoscopy, what can we do?
Well, I mean, you could do the fit testing and the stool collection, but if it comes back, positive, then the only thing we have is really colonoscopy. They also talk about CT colonography, which we do not have here at the hospital. That would be something that would be referred out. And then they also discuss about like a colonoscopy capsule, which we do not have here as well. But again, that's just evaluating to see if you have polyps. We do have barium enema at Reid Health, but again, that's evaluating if they have polyps. That's not going in to remove them to know what type of polyp. So again, the end result to evaluate for this is going to be a colonoscopy. Now, if there's people with risk factors in regards to anesthesia and their respiratory and that's something different. But majority of the patients should have the colonoscopy. There shouldn't be a factor that they can't unless they're nervous about the prepping situation, which a lot of people are, but then they come back and they order the actual procedure and they say, well, that was easy for something that could be preventable, right? Colon cancer. So, but again, the worst part is the prepping.
My neighbor told me it was really bad. And so,
Yeah.
I'm sure you.
Everyone. Yeah.
Yes, yes.
Yeah.
And so just trying, and is that part of your job to
To educate.
educate them and making sure that they do follow through?
Yes, yes. We explain the prep thoroughly to them, based on the prep that we're going to use with them and
To do
do as
some
much.
holding.
Yeah.
Yeah. We give them options too.
Yeah.
Like we don't want to say, well, but, people don't want the big gallon jug anymore, the new lightly, go lightly. But now we have a pill form with some Miralax and things that people do better. They're more tolerable to that than, the big jug. That's why I said, people say, I don't want the big jug.
Yeah, I don't want the big jug. Right. Yeah. Yeah.
First one I had the big jet.
They're like, we don't want the big
I
jug.
think that big jet psychs you out.
It does. It's intimidating, right? You look at this.
It's a lot.
If I'm not going to drink all of this.
A lot.
So regardless of you can act it fruity, you can do whatever. No, that's not a good thing. And the recommended frequency for some of the tests.
So, again, FID testing is yearly. The other stool DNA testing, that's every 3 years. And then if it's negative, okay. And then there are other type of stool testing as well. There's the FOBT, but fecal occult blood test. But there is some medication and dietary restrictions before you do that can make it a false positive. So, and that's usually like 3 stool samples that you collect. So you're looking at all 3. And then the screening colonoscopy, if you haven't had if there's no polyps or anything that's found, then of course that's 10 years. But then if you have polyps, then that will be based off of how many in the size. Dr. Raza would be the one who gives that follow-up of when the repeat would need to be.
And I'm back on the screening on this one. I'm looking at back on African Americans. It seems to be diagnosed with colorectal cancer at a younger age and have a decreased survival rate.
Yes. That's why screening is so important, starting at the age of 45. If there's no risk factors, and if there's risk factors, then we start earlier.
So I'm going to take you with me to a couple places so for better education purposes, just to let people to know. So, and to make sure that people, I think the biggest thing with screenings, people often will say the screening, they were afraid of the screening just because they were afraid to hear what the results were. And when often, more than likely, the screening isn't as bad. Or the results aren't as bad as people assume, but it's
the unknown.
Right.
Yes.
Until it's done.
What would you like people to know the most about getting your colonoscopy?
It's so important. Colon cancer is one of the preventable cancers. I mean, we go in or Dr. Raza goes in and sees the polyps and we remove them, so we're actually preventing the cancer from happening. So it really is a preventable, in some cases, cancer. So
And another thing is with family history.
yes, family histories plays a big role. You need to be screened early, and it's important to know your family history. A lot of people don't like to talk about this kind of stuff, but it's important. It's important to know what your parents.
So what are some ways that you can talk to family members?
Well, usually, usually that's something that the patient's going to have to discuss with them. And there are a lot of cases that a patient was adopted or they don't, they're not in contact with their parents or one of them, so they really don't know. At that point, I mean, you know, just knowing that history, they still, and if they've met the age for requirement for the screening, okay, but if they're being seen for something else symptom-wise, then it's different. It's no longer screening, even if it's before the age of 45.
And how can you arrange to get a screening?
Call our office. Call our office or talk to your PCP. Talk to your PCP for a referral.
We now have, it's orderable, so the primary cares, they're able to or are able to place an order for a screening colonoscopy. So as long as they haven't had a colonoscopy within the 10 years, or, you know, even if they've had a stool testing that was positive, they still can place a screening colonoscopy, and then that goes for office, and the girls will take care of it and get it scheduled.
And the biggest thing is like getting people to understand that just taking care of their health,
It's so important.
that's
so
helpful.
important. Yes.
And I like how you're saying that if you're at your primary care doctor can now do a referral. And so then it's probably somebody that they've known for years, that a trusted handoff, that's what I like to say.
Yeah.
Yes, absolutely. Yeah, that's orderable now, so they can place the actual order for that screening colonoscopy, and then our staff discusses that with them once they're scheduled. And you know, that's why my chart is very important now these days, because we're able to communicate with that and put their prepping information on there. So that's helped, and now we have care plans to help patients through when they are scheduled for their colonoscopy, to alert them, you know, today is when you should be starting your prep, and, you know, start with a clear liquid diet. And we also have outpatient services in regards to Rose. They will call 5 days ahead of time to ask the patients if they have any questions, making sure they have everything for their prep. And then they are called again, I think, a day or two before that too.
I think so.
And another thing is just trying to explain to people that to go through with it. Do you have people that just don't show, or?
Yes. Unfortunately, yes.
Yep, we have patients that just
They panic.
Panic.
panic, and
Yeah.
and then they don't go through with it. But you know, everyone has their own circumstances. So
And so that's why you're here to tell people, don't be afraid.
Yes. Yeah. It is important. So important.
Even if they're feeling healthy, they need to get screened. But
Correct.
yes,
Yes.
actually, where's your office located?
We're in the medical office building over at Reid.
Okay.
Suite 110.
Yep, Suite 110, all the way at the very end. But yeah, it's the medical office building. I kind of think of the hospitals in like 3 different buildings. We're on the building that's closest to Chester Boulevard.
Okay.
So
And you're on the first.
we're the first floor.
The first
floor.
First floor. All the way to the end of the hall.
Yep.
Got it.
Yeah.
And another, do you have like a success story you'd like to share of just somebody that maybe was a little hesitant?
I've had several patients, you know, that were hesitant about going, and they come back to me and they're like, it wasn't that bad. It wasn't that bad. The prep, you know, people hear horror stories, but it's not that bad. They need to understand the importance of why we have to clean out the colon, you know, so that we can see. Otherwise, the polyps will be hidden, and it's not as bad as people make it out. I think they kind of get things built up in their head, and
Stack gallons up. No.
yeah,
It's a jug.
it's the jug. Yes. Yeah.
Yeah.
So that's great.
Yeah.
Well, I want to thank you both for joining us today.
Thank you.
And thank you for joining us on Let's Talk Together.
Let's shine by seeing the best in all of us and by treating you here, right in your hometown. Let's look out for each other. Let's stay healthy. Let's shine together.